right, how's everybody doing? I've met hardly any of you, maybe two faces. I'm Cam Golightly. I'm one of the new nephrologists. Joined the group with Nephrology Associates in August. Just came from residency and fellowship, so hopefully some of my stuff isn't over y'all's head, because I was trying to remember what I needed to know for internal medicine boards and what I needed to know for nephrology boards. So I'll try to keep it at a good spot, introduce you to a couple things you may or may not have heard, a couple things that an attending may try to sound smart talking to you about, and it'd be good if you already know what they exist. Probably not know what they are or how to treat them or anything like that. Got a couple questions in there, some that I stole from old Mixapp, and then a couple others I just kind of made up related to actually a couple patients I've had already. About me, from North Carolina. Feel free to reach out. I'm actually from South Carolina. I did residency and fellowship at Wake Forest. So anybody who is thinking about nephrology, it's not that horrible. Well, I mean, I know, like I was looking at it and had decided I was going to do nephrology. I was initially thinking sports med, ended up going nephrology between first year and last year. Quality of life's pretty good. Pay is pretty good. A lot of the things that all the Medscape stuff that you get emails about that say it's absolutely horrible, it's not actually the case. So if you have any thoughts about it, please reach out. Our program, we had an inpatient nephrology service, and so nobody ever wanted to do nephrology from Wake Forest because it was all the same 5, 6, 7, 8 patients that weren't always the most pleasant to be around, that would always keep coming in and out. So, all right, I'll take this off from, it's on at least 20 feet away from everybody. All right, so secondary hypertension. I don't know how many actual questions you'll get on boards on secondary hypertension. A lot of it's primary, and then you'll kind of see a little bit of them smattered. You'll just have to see if you're actually catching that they're trying to get you to look into a secondary cause or not. So we'll talk a little bit about blood pressure stuff, basic treatment, and then kind of hitting on a couple of these different other topics. Some of them that are probably going to be diagnosed before y'all actually ever see the patient, as in they should have probably been found in pediatrics. So hypertension, y'all would have started med school when? What's the earliest med school? Tina, you probably were the earliest on the med school. When did you start?
I was later.
Okay.
So
2013. Okay. So I started med school in 2012. And so the guidelines for hypertension have changed, I think, 3 times already. So they're all kind of the same general trend. The current guidelines, they change, and they're certainly variable, whether or not you're looking at JNC 8. When I was going through med school, it was JNC 7, then you got JNC 8, American College Cardiology, and then KDIGO. I'm a nephrologist, so I'm going to follow KDIGO. But really, in real life, this is not necessarily the board appropriate stuff, but treat your patient. You're going to have these guidelines. They are guidelines. The most important part is the KDIGO stuff actually gave physicians a little bit more leeway, where aggressive care unless you feel like it's not needed. And so always consider your other stuff that's going on, your dementia, your end of life care, what the other disease processes are ongoing before you try to just hammer down to certain benchmarks. So diagnosis of hypertension, again, this is likely review for everyone. Sorry. 2 or more readings on separate occasions. As you see here is your landing spots. When I was starting, like I said, hypertension was defined at 140/90. The other stuff that you will see on boards, I had a couple of questions about it for internal medicine, was your continuous ambulatory blood pressure monitoring, with your goal there being 125/75. And that is good enough, just a daily reading of blood pressure being over 125/75 to make your diagnosis. And then your other thing that's actually really important, I didn't remember that being a big deal when I was coming through training, was as you all know, who worked nights, you'll get called because so-and-so at 3 a.m. in the middle of the night has a blood pressure that's dropped down low. Do you want to give them fluids? Are they okay? You wake them up, they're perfectly fine. So you should have that dip down in your blood pressure overnight. If you're not, that's actually a really bad sign for that patient's prognosis. Means that they got some sort of other real organic disease and need to kind of figure out what's going on there. Exceptions to this, if blood pressure, somebody walks in with blood pressure 180/120, or blood pressure that's 160/100 with other signs of in-organ disease. All of y'all know this by now. The real quick treatment, like I said, the view from 30,000 feet, pretty much lifestyle modifications are your first steps. Cutting your alcohol use, making sure somebody's actually getting some form of sleep hygiene. And then trying to follow a low salt diet. JNCA, a lot of those others say the 2,400 milligrams a day. I usually try to push people to 2,000 milligrams a day, knowing in reality they're close to around 5 to 6 grams of salt a day. Hopefully you can get them down to something that's at least more manageable. Again, starting therapy, most guidelines kind of follow around 130/90. Your first line therapies, your ACEs, your ARBs, your thiazides, calcium channel blocker, second line beta blocker. I will personally pull for a beta blocker a little bit sooner if they've also got some other heart disease or some other reason why. And then your third line are all kind of your other ones that get added on. Again, picking and choosing your medications there based off of what else you're seeing. So resistant hypertension. This part is very important to know. And you will get a question that's going to be either directly address this or will be very closely indirectly associated with this. So blood pressure that's not at goal, despite being on appropriate regimen, which includes that you're on full dose therapy, you're on drugs from different classes, and one of those, and that's the big asterisk here, is one of those must be a diuretic. So you can't call somebody resistant hypertension. You can more than welcome to always send patients to me, but send them over to me for blood pressure with being on a diuretic. And you'll hit your right benchmarks there. So when should you be concerned about somebody's blood pressure? Obviously, if somebody walks in the door with blood pressure 220 or something like that, we're going to be concerned. If they have other electrolyte disorders that don't really make sense, if they're acidotic, if they're alkalemic, if they're hypokalemic, hyperkalemic, any of that sort of stuff. But those first two are probably the big things to really keep an eye on. If you've got the same guy who's been coming through the door, follows up every 6 months, everything's been great, his pressures are usually 120s, 130s, and the next time you see him, they're like 140, and then the next time you see him, it's 150, 160, something's changed. And so that deserves more than just putting another medication on and really talking to see why is your blood pressure all of a sudden been shooting up. And certainly when you have a young age. And if any questions at all throughout the process, just ask. So initial workup, check your salts intake, food diary, education. CDC, I think, came out, I guess now it's been about 6 months ago, that they're going to start trying to put sodium levels on foods that are at like your fast food places, similar to what they did with the calorie count a little while ago. I think that's going to hopefully help a little bit. And then you can do your 24-hour urine collections. This is going to be something that's more nephrology, but you can do it as well. I actually had a bunch of questions on my nephrology boards where the answer was lower the salt intake. So you may start seeing that in your IM boards as well. Ensure the patients are actually taking the medicines. Don't just say they're not compliant. We in medicine have gotten horrible at just saying so-and-so is not compliant without actually addressing why. Is it because when they take 5 pills at one time, they're throwing up 10 minutes later, which I've witnessed, I'm sure we've all witnessed? Is it medicines? Is it they just are lazy or whatever it is? Try to see if there's something you can address. A lot of times you can't. It's just that's what they're going to do. They don't want to. They're going to do their own thing. But take a look at that. Make sure they don't just have white coat. You can do your ambulatory blood pressure monitoring. I don't know who does that here or what department that's through. I haven't learned that yet. Where I was training, it was like weirdly through vascular surgery. That did the blood pressure monitoring program. That's who you had to set them up with. As an internist, I put this because obviously the way I'm going to assess somebody coming to see me in the office for secondary blood pressure is a little different. But as an internist, the first couple steps, assess the renal function, just get a BMP, and then you can think about doing a renal artery duplex, particularly the folks that are really young or the ones that are older with some sort of vascular disease already that you know of. So most common cause of secondary hypertension, this is a question, or one of the most common causes. What do y'all think?
Renal artery stenosis.
What is it? Sleep apnea is a little bit, but you're not going to get a whole lot of bang for your buck with that. But that's one everybody thinks about. Sleep apnea is really only like 3/2 or something like that. It's like minimal, but it does. What kind of doctor am I? So just kidney disease, not necessarily renal artery stenosis. So just chronic kidney disease. After 30% kidney function, 80% of those folks are going to have high blood pressure, and usually they're going to have them before then. So chronic kidney disease is the most common cause that you can see of your secondary hypertension. What I said, or glomerulonephritis is also going to follow with hypertension. And what you see there is you get your sodium retention, your increased RAS. So that's all I'm going to really talk about a lot on CKD. So mix-up question. Anybody want to read it or? Go ahead.
And CKD symptoms, medications are listed. I'll just go through blood pressure is 180 over 100, both are obese and creatinine is 2.2, and protein creatinine ratio is 4 grams.
All right.
Which of the following is the most appropriate treatment?
What do y'all think? So we got a 45-year-old guy. His blood pressure is not a goal. He's got a little bit of some swelling in the legs. BMI's up. He's got CKD. He's got protein. K is normal. What would y'all do? D?
Yeah.
Yeah. Switching the hydrochlorothiazide to the Lasix.
2%.
Clonidine, you got other options. Allospirin, don't really need to do that. He's already on lisinopril. And then minoxidil. One thing that's with minoxidil, a lot of folks don't use minoxidil for blood pressure. I hate it personally for blood pressure, but it is something there. But you got to make sure you got a patient that's euvolemic, because the big thing that you see with minoxidil is the pericardial effusion, and that can become more pronounced if somebody is not volume managed. You'll see that at least one time in your career. So like I said, CKD, goal blood pressure. The new guidelines for KDIGO are less than 120 over 80, but don't induce hypotension. Most folks seem to still kind of be following the 130 over 80. That was in the later KDIGO stuff. Again, this isn't stuff for y'all. Sodium restrict, ACEs and ARBs, your mainstay. Continue those really until the benefit's not there. What I mean by that is if their blood pressure is needing the ACE or an ARB, I'll continue their therapy until they're getting persistently hyperkalemic. And usually that's around 15 to 20 on their GFR. The diuretics, I don't know if this will follow with y'all or not. I think it'll probably be that board question, which is why I put it on there, which is when they get below 30, to switch them from the HCTZ to the loop diuretic. That's an important thing to reach for. Again, if they're getting below 30, you probably should be sending them to see a nephrologist anyways, and we can just handle that. But you will still get those questions. You'll get more questions like that than you think on your boards. However, the newer literature actually doesn't support that as much. There was an article in C. Jason that came out recently that said, we used to think this was around 30, but you can try these folks on chlorthalidine, you can try these folks on HCTZ and see how they do. Now, if they're not, or if they have legitimate edema, then you can put them on the loop. And usually they're gonna need some sort of medicine to eat. All right, another question. I think I've only got 4 questions, so. Anybody?
7-year-old with coronary disease, CKD, hypertension, diabetes, presents for routine physical and follow-up medications are LSR 25, statin 5 at 500. No new symptoms or complaints. Blood pressure is 150 over 94, heart rate 73, AKB brow, respiratory 17, BMI 27, no peripheral edema, otherwise benign event. Creatinine 1.6, 1 year ago 1.5, sodium 40, potassium 4.35, carbon 33, SART has increased to 50 today, returns to office 4 weeks later, feels okay, the blood pressure at that time is 180, same change, blood work 2.3, sodium 40, potassium 4, back carbon 21.
So what are y'all's thoughts? So this is actually one of my clinic patients. So I don't know if what I did is correct yet because the tests haven't been performed, but this is what my thought was. So what are y'all thinking? What would y'all do here? Yeah, that's what I decided too as well. So 77-year-old guy, been stable for a while, blood pressure all of a sudden starts freaking out or creeping up. creatinine all of a sudden starts jumping as you crank or as you increase the losartan, but not a whole lot of dose there, only a 25 to 50 milligrams. So renal artery stenosis, you're going to get a few questions on this, of course, and renovascular hypertension. It's really important to try to catch this early. Your board questions are probably going to say once you're there, you just do medical management. We'll talk a little bit about that because that's based off the Corral trial and the Astral trial. But the things here, so a little bit of a bimodal distribution. Your young folks, you're going to be dealing more with the fibromuscular dysplasia, usually follows with your females in their 20s, 30s. And then the other is your atherosclerotic disease. This right here is a picture of fibromuscular dysplasia. What you'll see is the beads on a string sort of thing going. It can be unilateral. It can also be bilateral as well. Your atherosclerotic lesion is not going to get that kind of squiggly line appearance. You're just going to see their actual narrowing. Those folks are going to have some form of usually other arterial disease. The kidneys aren't special. If you've got cardiovascular disease, if you've got cerebrovascular disease, if you've got peripheral arterial disease, you need to be on the lookout for possible renal artery disease as well. So what you'll see here, kind of your benchmarks here, onset of severe hypertension, I mean, really high after 55 years of age. You start seeing a pretty abrupt decline in your renal function when you start doing any hypertensive therapy, but particularly you start seeing it with your ACEs and ARBs. And the point where you start seeing with any blood pressure medicine, whether it be diuretics, amlodipine, beta blockers, any of that sort of stuff, is going to be when you get to that critical level of your stenosis and when you start trying to control their blood pressure, essentially you've dropped their perfusion pressure. Your sonograms or your CT scans are going to show some asymmetric kidneys. Your solitary kidneys, your transplant patients, your other folks that already were born with one kidney or had some sort of congenital issue, you got to have a little bit more of a higher index of suspicion there as far as what may be going on. You also will start seeing your recurrent flash pulmonary edema. That's another thing to keep an eye out. These folks that they can't stay out of the hospital with their heart failure issues. Your abdominal bruit, you'll see that on the exam, real life, and kind of hit or miss. Doesn't have a great sensitivity. And then also always think about this, your patients that have had an aortic dissection when you're in the ICU or when you're following a patient that's moved out. If you start seeing difficult control blood pressure after aortic dissection, start worrying about was there any involvement in the renal artery? Take a look back at that CT scan. So what's going on here? Here's your renin-angiotensin system. So when you get your renal artery stenosis, what you start seeing is you have decrease in renal perfusion. This activates your renin, then goes through your angiotensin. Oops. And then ultimately activates your increase your sympathetic tone, your adrenal glands, leading to aldosterone, your arteriolar vasoconstriction, all that sort of stuff. So in theory, your ACEs and your ARBs should be good treatment for this. This is actually what they recommend for you to do, ACEs and ARBs when you're doing medical therapy, as well as possibly diuretics, which is what we have right here. So renal artery Doppler, this is actually something that you will see. I don't know how well they will ask that on your question. This is what you're always going to have in your review system, is knowing if your texts are good. And it'll say something like, it'll say good quality tech or something like that in your question. So I don't know if they would really ask that. Otherwise, your CT angio, MRs, which never will get paid for. And then your gold standard is going to be your renal arteriography. That was usually like your step one questions and things like that. What you're seeing on your renin and aldosterone are both going to be high renin and high aldosterone because your kidneys think that you're volume deplete. So increasing your sodium retention, sympathetic tone, vasoconstriction, that whole process. Medical therapy is the mainstay for this based off of what medicine thinks. Surgery doesn't always agree with that. So ACEs and ARBs, thiazides, diabetic management, statin, platelets. And the reason why I say surgery doesn't always agree with it. So if you send these people to a vascular surgeon, they're probably going to go in there and intervene. So again, you're putting a nail in front of a guy with a hammer. And so this other stuff here, fibromuscular disease, not as much of an issue. So this is why you need to refer to vascular surgery in your select patients. So the medicine literature says just medical management. Don't go and intervene on these guys anymore. And they base that off of the Corral trial as well as the Astral trial. And the reason is they saw, as you can see here, there's no benefit one way or the other for medical therapy versus surgical therapy. However, the folks in these studies, they didn't make any difference whether or not somebody had just gotten issues with high blood pressure in the past couple of weeks, past couple months, there was no effect of that as far as when their blood pressure got uncontrolled in the randomization. And they removed patients that actually would benefit the most, such as those that are frequent admissions for heart failure, frequent admissions for flash pulmonary edema. So you need to keep that in mind. So with that said, the folks that benefit from revascularization are those sort of folks, the guys that have new onset or recent hypertension, previously normal renal disease. If the lesion is more distal, they're going to benefit a little bit more. And if they keep having the recurrent pulmonary edema. When they go in there, they need to stent it. They don't need to do angioplasty, and endovascular is preferred. All right, questions on renal artery stenosis. That's probably as much you will ever need to know for your boards. No, okay. Next question, and I think there's this one and one more.
No family history of difficulty results from hypertension. My chest pain, shortness of breath, edema in lower extremities, pain is well controlled. No over-the-counter medications. Medications include HTTP 25, Cinepril 40, daily amphetamine, extended release 30 milligrams, hydralazine 25 TIV, and his blood pressure today is 158 over 1, heart rate 64, respiratory rate 18. On exam, his BMI is 31. He's muscular build. Lungs are clear. Cardiac is edema, abdomen is soft, no bruise. Starting with 1.2, the potassium of 3.6, chloride 103, bicarb 29, UNF 18, creatinine 29. UA has some trace protein. There's protein creatinine ratio of 450.
And this is also a real patient, so what would y'all do? So we got a young guy, blood pressure is not controlled. The CRPS is the complex regional pain syndrome. I don't know if that's still a thing or not. Yeah.
I would probably say D in this case. He's got some at least lab indicators. They probably some hyperaldosteronism, although K and a high CO2.
mhm.
So, no way.
Okay, that's a thought. Any other thoughts? Okay, yeah, that's what I would do too. The renal artery duplex, I mean, he's young, you don't really have a clear reason. You'd be okay checking the renal artery duplex, but that's probably not the next best step. Kidney biopsy, he's got some protein, but his blood pressure's been elevated, persistently elevated. You'll get increased hydrostatic pressures from that. So you'll get a little bit more protein in your urine just from the severe uncontrolled hypertension. No other symptoms for plasmapheresis. And yeah, checking the aldosterone and renin for the exact same reasons. Blood pressure is uncontrolled. He's on multiple different medications despite this, including a diuretic. And just what you said, his bicarb's a little on the higher side, his K is on the lower side. And his sodium's a little up there as well. So hyperaldosteronism, this kind of, you'll see this on nephrology review as well as on endocrinology review. Look at your chemistry. It's maybe a little bit subtle, kind of like where that one was. And the couple of things you'll see is a low normal K, or you put somebody on just like a 12.5 milligram of hydrochlorothiazide, and the next time they come in, their potassium's 2.8. I mean, a real sharp decline there. The metabolic alkalosis is kind of hard to, I want to hang your hat on that. You should have a metabolic alkalosis, but nowadays with so many folks having Pickwickian or OSA or chronic COPD, I mean, I just moved from middle of Tobaccoville, USA. So everybody was smoked starting at like age of 7. So you'll always have this chronic metabolic alkalosis. You're not going to get your sodium that's actually elevated if somebody's able to get up and walk and get a glass of water. It won't be, it's just not going to be over 145. So you also can get your secondary hyperaldo type processes from renal artery stenosis. That's going to be a high renin, high aldo state. Aortic coarctation is going to be the same way, but then you also get a little bit more with some of your diabetes and obesity as well too. So primary hyperaldo, your workup's going to be checking your early morning plasma renin activity and your plasma aldosterone levels. And what you're looking for there is to see a PAC to PRA ratio of greater than 20. So renin should be turning on aldosterone. If it's not, the renin is turning on the aldosterone. It's a primary hyperaldo type process. Your levels, aldosterone should be greater than 20. Sometimes I'll say greater than 15. They probably won't be real shy on that on boards for you. And your renin levels should be less than 1. That's the other thing you look at. Now, if you got somebody on the lisinopril or something of that nature, or an ACE, you may see a PRA that's greater than 1. That doesn't rule out disease, but it's usually not going to be like 5 or 6. You can do a 24-hour check to make sure there's no sort of adrenal tumor with a Conn syndrome type process. And you confirm this by doing a saline infusion test, or you do an oral sodium load or a salt load. You do want to make sure these people are relatively controlled on blood pressure before you do this, because if you have somebody that's going to cause sodium retention and you give them a whole lot of sodium load, it can cause their blood pressure to go to like 190 or something like that. So try to get it relatively well controlled just in practice. Your interfering drugs, the other thing is your MRAs. I spent like a whole year trying to get this guy's blood pressure under control. This patient actually, before I put him on Aldactone, I knew Aldactone was going to be the treatment, but we were in an academic center, so we wanted to do everything by the book. And so we finally got it done, and we did the test. And at the end of the day, we're like, all right, sounds good. Here's your spironolactone. So treatment: spironolactone, eplerenone, propafenone, Corindia, whatever that is. As a newer one out there. Spironolactone will work just fine. Talk to them about the gynecomastia, talk to them about the hot flashes before you put them on it. Titrate that up. And that's, partially until they get to their blood pressure under control, but treating up to hyperkalemia is what you're shooting for there. If that's still persistent, you can send them over to endosurgery or onc surgery, whoever you got at your center. The other stuff that you may need to know exists. Littles you may hear about on your boards. You may get a question or two in your mix app. So Little syndrome essentially is an autosomal dominant. It's an inherited process. So you're going to have your strong family history of difficult to control hypertension. You can send some genetic testing that'll get you your diagnosis. But it's a gain of function mutation in the ENaC channel, or and so you'll see your hypertension, you'll see your hypokalemia, metabolic alkalosis. You treat this with a miloride, but your aldosterone and your renin levels are going to be low. So essentially it looks just like primary hyperaldosteronism, except both of those are low. Your other things, your mineralocorticoid excess, congenital adrenal hyperplasia, again, probably should have been caught in pediatrics, but if you had somebody from the sticks that just now moved into town, never seen a doctor in 25, 30 years, may not have caught it. Licorice, actually, that's another one. So I actually will ask people routinely if they have an affinity for licorice, and it's the true licorice. It's not like Twizzlers or some of this European stuff, or American stuff. It's the true legit licorice. Can impair some of the enzymes there as well. Syndrome of apparent mineralocorticoid excess. I actually had a question about this on my nephrology boards. It's like 5 cases in the world. You probably aren't going to have that on yours, other than to know that it exists. And it's a deficiency there you see in the enzyme converting cortisol to cortisone. And then glucocorticoid remediable aldosteronism. Again, you treat these with prednisone instead of your other types of mineralocorticoid blockers. Used to be called familial hyperaldosteronism type 1. I've seen a couple cases of it, so you'll probably see this in real practice. I don't know if you'll see it on your boards. Just know that it exists. Pheochromocytomas. If you are like me going through med school, you probably thought that these were going to be like every other week you're going to see one. Like that, myasthenia, all those things that were on every single test in some way, shape, or form. So tumoral secretion and catecholamines, your classic triad: episodic headache, sweating, and tachycardia. Third of the folks will also have this paroxysmal elevation of blood pressure, where they have this elevated blood pressure and then they have orthostatic hypotension. Again, we assess for it more often than not. We probably don't need to be, but again, it's something that if somebody's going to go surgery or something else like that, it can kill them. More often than not, you should be working it up if you have your adrenal insulinoma. And then also start thinking about other things that can interfere with that. So stop your interfering drugs. This can be like your MAOIs, some of your SSRIs, your amphetamine kind of derivatives, a bunch of those other things there. Always look those up before you start running these tests. So your first line, this is actually important. Your folks that are low risk, like when you're just like, secondary hypertension, do your 24-hour urine tests before you go through a lot of other unnecessary tests. If you actually have somebody who has a lot of the symptoms, if they have a family history, or if they have one of those cancer syndromes, or pheochromocytoma is on the differential, That's when you do your plasma fractionated metanephrine. The reason why that's not first line, even though the one that we actually usually all order, because it's a lot easier to just do a blood test as opposed to asking somebody to collect the 24 hours, is your plasma metanephrines do have a good bit of false positivity rate. So before you start going through a whole lot of other unnecessary testing, you should check a 24-hour urine before doing that. Treatment, alpha blocker, phenoxybenzamine is what everybody says, and then do a beta blocker, usually post do propranolol, and then referral to surgery. And that's all I'm going to talk on PHIOs. Hypercortisolism, Cushing's, again, the rest of this is just kind of brief. They're part of my area, but when I diagnose them, I send them to endo. Can mimic your hyperaldosteronism, overproduction of your ACTH, again, your deoxycorticosteroid, corticosteroid, cortisol. Again, elevated cortisol is going to be your diagnosis there with high blood pressure. And your pathophysiology is you're getting your sodium retention lead into your hypertension there. OSA, like I said, a lot of us think that that's going to give us a whole lot more bang for our buck. It does cause high blood pressure. It's not as much as what we think. And as you can see your symptoms, that was a very bad joke. I wrote it, whatever, 11 o'clock one night when I was writing this. Just tired all the time, yeah. Coarctation of the aorta, hopefully caught before it gets to us, but it's us as an adult medicine folks. But you'll see a chest x-ray when you're doing your boards. You get your little 3 pattern here where you're missing your aortic arch shadow. Your bilateral upper arm extremity should have hypertension, but then you get hypoperfusion of your legs. You'll see it this radiofemoral pulse delay. That's a quick thing that you can do in your office. Check both your pulses in your arms and then in your femurs. It should not be all at the same time. And then you get your systolic murmur. Thyroid disease can both cause this. Both hyperthyroidism can cause you to have systolic hypertension. Your hypothyroidism can cause you to have diastolic hypertension. Things to always keep in mind there. And I believe this is the last question. So who's the last one that wants to talk? All right. 57-year-old woman came in for a pre-op physical for a total left knee replacement, medical history for osteoarthritis. Only med she's taken is over-the-counter ibuprofen, takes it multiple times a day for pain. On exam, she's hypertensive to 152/90, heart rate's fine. She's obese. She's got horrible osteoarthritic changes in her left knee. She's got some edema at her ankles. Remainder of her exam is unremarkable. Labs show creatinine 1.2, K is 5.1, urine dipstick is bland. Which of the following is the most appropriate next step in management of this patient's blood pressure? Start them on an ACE, start them on HCTZ, stop their NSAID, or attain plasma aldosterone to renin. What do y'all think?
Without there even being a stem, I would have said C.
It's a good man. Yeah, stop their ibuprofen. Y'all know this. It's a great drug. I mean, it really helps, but just kills so many things. All right, so medications, NSAIDs and steroids both cause your sodium retention, can cause your high blood pressure. Your VEGF inhibitors, so somebody check to make sure what their medicines they're maybe getting for injections into their eye. There should not be a whole lot of systemic absorption, but there is some. So if for some reason your diabetic patient that's been following with ophthalmology that's about to go blind, their blood pressure starts getting difficult to control, that could possibly be, doesn't mean that we necessarily stop it. It just means that may be where we're coming from. TMA, so thrombotic microangiopathy, definitely one of the characteristics of that is hypertension. So a lot of your chemotherapy agents, your bevacizumab, other alkylating agents, gemcitabine, a bunch of those other stuff, your immune checkpoint inhibitors cause nephritis, again, leading to hypertension, and then the other stuff there as well. Last slide here. So other stuff that you see that can cause some of your secondary hypertension stuff. Sclerodermal renal crisis. Your question sim, you'll probably see this in boards before you see it in real life, but you will see it in real life. So folks will come in, acute onset rising blood pressure, should see some form of skin findings. Hopefully you don't have a patient that their first presentation is renal involvement, because it likely will delay their diagnosis, and this is a rheumatological emergency. Captopril, something that's fast on, fast off, is going to be your treatment of choice there. Page kidney, and this is where essentially you get a large hematoma around the kidney and essentially just pushes in on the kidney around the capsule, activates the renin-angiotensin system. Not much you can do there. You just put them on an ACE inhibitor, get urology to come by and bless them, and say that we'll follow closely with you, and then they won't see the patient again for 4 weeks. But because there's nothing else for them to do really. And then your renin secreting tumor is exceedingly rare. Hyperparathyroidism, yet to actually see this, at least I don't think I have. Maybe I have and didn't look the right direction. But your hypercalcemia, that leads to decreased vascular pliability. And then pain, always remember that. Don't start treating somebody's horrible blood pressure, particularly in the hospital if they're in a lot of pain. Get their pain under control first before you start doing this other stuff. Pain also can cause SIADH too, if y'all don't know that. All right, questions? Yeah.
If you're, when you're checking renin and aldosterone, do you try and come off of the blood pressure agent before to do the test, or you just know?
As long as they're not on aldactone. If they're on aldactone and you're wanting to do that, I would get them to come off. That medicine will last in your system about 24 hours. So I would try to stop the aldactone around 3 or 4 days. The other flip of the coin with that is if they're on aldactone and you got that therapy up to good targeted therapy, I mean, you can send the test. And this is kind of the academic versus real world private practice sort of thing, because those tests do take a few days to come back. Those tests aren't cheap either. But if they're already on the therapy for it, but yes, that one will interfere. You don't have to take them off your ACEs and ARBs, but that just know that that may cause your renin level to be a little bit higher. What other questions? See it in the chat. I think it was just everybody checking in. Oh, yeah, they were trying to. Fair enough. All right. All right. Truly, if y'all have any questions about anything, about nephrology, about other things in life, shoot me an email. More than willing to help you out and stuff. All right. All right. No problem. Let's see. So recording.